Hi, you're watching DNA Today, a multi-award-winning genetics podcast where we explore everything to do with genetics, from CRISPR to rare diseases to new research. We have won the Science and Medicine Podcast Award for many years now. We have hundreds of episodes, and we really hope you enjoy these conversations where we dive into so many genetic concepts. I'm Kira Deneen, a certified genetic counselor and your host. What if we could ease the suffering of patients with undiagnosed diseases or rare diseases? In this episode of DNA Today, we dive into how genomics is reshaping care for some of the most medically complex patients, with a particular focus on the genetics landscape of Turkey, as both of our guests are joining from Turkey. So we have Professor Dr. Serdar Ceylaner, a medical geneticist in Turkey and founder of Intergen Genetics and Rare Disease Diagnosis and Research Center, along with Alice Pong from MGI Tech, a leader in genetic sequencing innovation. Together, we're going to explore how cutting-edge sequencing is accelerating rare disease diagnoses and improving quality of life for those living with these conditions. Hello, thank you both so much for coming on the show, Alice and Dr. Ceylaner. Really appreciate it, especially we're coming from multiple time zones on this call. So thank you so much.
And thank you for your invitation.
Now, Dr. Ceylaner, you're based in Turkey. Can you describe the genetic testing landscape there and how it compares to maybe some other countries? I'm based in the US. A lot of listeners are in Canada, the UK, many other places. But can you share a little bit with us about what that genetic testing landscape looks like?
When we compare it with some other countries, it is better. Because there are several genetic centers in all over the Turkey, nearly in 41 cities, and totally we have 81 cities, and you can reach a genetic center if you will move just 50 kilometers in a way, and then you can reach a geneticist and you can call a geneticist in Turkey. On the other hand, all kind of genetic tests easily reachable in Turkey. And some of them are under the payment of the social security system, especially in some public hospitals. They are making the panel tests and chromosome analysis, RACGH, and some others are under the payment of the social security system. And the only problematic test is whole genome and whole exome sequencing. In those tests, patients must pay themselves. Nearly 3 years ago, government also paid those tests, but they decided to cancel it. But on the other hand, it is much more easy to reach a geneticist because you can call a geneticist or you can reach a geneticist in a public hospital, and the consultation system is working well. And not only in Turkey, we are serving the other countries. For example, in our center, we are working with 20 different countries, and they are consulting their patients. In Turkey, there are several clinical geneticists, but the main problem is clinical geneticists are mostly placed in the public hospitals, and the private genetic centers are very big, and most of them has very good infrastructure, but they are mostly do not serving in the clinical area. The clinical practice is mostly going on in the public hospitals and universities. That's why we are now trying to develop this clinical service also in the private sector.
It's interesting that a lot of neighboring countries end up coming to Turkey for care. It's a hub for genetics and people to be able to get treatment. One of the aspects I think about of Turkey and also Qatar, an episode we'll link to in the show notes, is that both of these countries and some others in the area have a relatively high rate of consanguinity. So people that are somewhat closely biologically related having children. How does this affect the prevalence of rare diseases and also dual diagnoses?
One other interesting information, we also has an online hospital now. Our center is arranged that. That's why we are not serving just face to face, and that online hospital is mostly focused on rare disorders, and we are serving by using the technology and the internet conditions. By this way, for example, yesterday I evaluated a patient from United States. Today I evaluated a person in Canada. Last week, I evaluated a person in Argentina and Paraguay. These countries are easily reachable, and now most probably this will help us to enlarge our enrichment. And now in this online hospital, we are trying to invite all other rare disease focused doctors and geneticists together to evaluate these patients. Many countries cannot reach these surveys. On the other hand, in Turkey and some other countries, we have a very high consanguinity rate. The rate is nearly 25% in Turkey. And there are some other countries like 50%, 40%, and this is unbelievable. And this is causing a main problem. The main problem is most of the guidelines prepared for United States and Europe is not working in Turkey. Because recessive disorders are very common, homozygous dominant disorders are common, and there are very few cases like that in the literature, and most of the guidelines are for the countries who has very few amount of consanguinity. We are using whole exome sequencing and whole genome sequencing much more than the other countries, because we are also seeing, for example, when we are making a screening study in a consanguineous parent randomly, we are detecting 34% of recessive disorders sharing mutations in 34% of them, and in 8.4% of them, we are detecting 2, 3, 4 different disorders, sometimes 10 different disorders, especially in the inbred areas. And this is causing a mixture of clinical pictures in some of the babies. And for example, nearly a week ago, I evaluated a skeletal dysplasia patient, and the skeletal features is not resembling any disorder, because there is two kind of recessive skeletal disorder at the same time, and it is mimicking several other disorders. It's a very common thing in Turkey. That's why we have to write our own guidelines, and we have to use whole genome, whole exome as testing very frequently. But it is not so complicated to reach. That's why we are not living a big problem. The only thing is we are making a pressure on the government to make them pay the tests. Otherwise, some of the poorer towns or villages are very difficult to reach these persons, these tests.
That makes sense that with the different patient population, you can't use guidelines from other countries that don't have that same rate of consanguinity, and that you're going to get more autosomal recessive conditions, especially the rare diseases coming up, because it's a gene pool that is a little bit smaller in some ways. So that makes sense that you're ordering whole exome or genome as your first line testing, because if you only ordered panels, you wouldn't be finding some of these rare diseases. It's interesting you said 8% end up having, you said multiple diagnoses or a rare disease.
Diagnosis, yeah, it's very common. On the other hand, I'm thinking that if we are following a chronic disorder, we have to know all the genetic background of the patient also, because sometimes we have to give some complicated decisions, and that complicated decisions cause some side effects, and that side effects can be protectable by checking everything. Especially in Turkey, second, third disorders are common. Now, on the other hand, in all the world, autoimmune disorders or some immunodeficiencies or some other overlapping disorders causing problems, and pharmacogenetics is a big problem, and that's why we have to see everything. It's a chronic disorder, lifelong problem, and I'm sure that, and most of the studies clearly presenting that this is reducing the cost and increasing the life quality of the patients. And during our daily life, we are trying to behave like this.
Yeah, it seems like it's so important to be able to order whole exome or genome to be able to get that answer, to then have proper treatment and be taking in the full clinical picture. Alice, what is the turnaround time for whole genome exome sequencing for MGI? How does it differ if we're comparing it to other types of testing that we have?
Actually, when we're talking about this topic, I also have something that I want to share, especially
Please.
for Turkey market. Since 2020, actually, Professor Serdar, he became one of our KOL, and he was the first reference lab in Turkey. And he installed our high throughput G400 system. This one I remember in that time, one of the reason that he decided to change to our platform and use this hundred, it was because this platform make him be able to sequence from panel and change to WES. Because this machine has a very high throughput, but in the meanwhile, it's very cost effective. So this one give the opportunity to Professor Serda, and meanwhile in the doctors, clinicians, to give them this opportunity to do this whole exome for their patients. And about the turnaround time, if you are using G400, of course, the turnaround time, because it's an old system, so the turnaround time can be a little bit longer. It can be around 1 week or 1 week and a half. I mean, from the sample preparation to the report. But in every year, MGI, we are releasing new platform. For example, we have our G99. This one can finish PE 150 in 12 hours. So this give the clinician a chance that to finish the whole exome, just the process within 6 days. So they can be able to give a report. And we are also improving ourselves because G99, the throughput is not enough. And Professor Serdar, after they adapt to our G400 platform, they also upgrade to our T7, the ultra throughput platform. And this year we released the T1 Plus, which can finish the PE 150 and generate the Tera-based data within 24 hours, same as our T. So all of this technology support, I think it's giving the market, Turkey, and not only Turkey, also globally, giving everybody the chance that to switch from the small panel into the whole exome.
And that's where we're going. I think at some point,
Yes.
panels are going to be very rarely used, and it's just going to be exome or genome. I think you said 24-hour turnaround time for the fastest. So that must
Yes.
be the rapid one that I
Only
imagine.
the sequencing one. For the sequencing
one.
speed, yeah.
I see. Okay, yeah, that makes sense. Because I was like, wow, that is very, very quick. And that, I imagine, is really important to have options for very fast turnaround time when we have a critically ill newborn, where, Professor, you were talking about that we need to adjust treatment sometimes based on the diagnosis. I mean, that's just common sense, but that it can save lives when it's a really, especially critically ill newborn or even kiddo. What percent of these cases are you, if you had to guess, are you using the rapid version to be able to get that answer as soon as possible? And like, how much does it really change care?
We are doing it very frequently because I and my wife is working in an interesting area. We are working in intensive care units. And yes, we are consulting several other kind of patients, but we are also consulting several intensive care units, not only in neonatal period, but also the patients. And if you are evaluating a patient in intensive care unit, in pediatric patients, nearly 50% of them has a genetic disorder, or in adult, it is 30%. These are the Australian numbers. This is
Okay. So I would imagine it's higher in Turkey.
Yeah, especially when you are going to the eastern part of Turkey, it is about 90% or something. Because especially the metabolic disorders and some neurological disorders are very common. And that's why we are using this very frequently. And I'm both counseling directly, or I'm counseling online. We are doing this very frequently. We can report in 3 to 6 days, and we have a very rapid algorithm in the bioinformatics side. And we developed our own strategy for the detection of and classification of the mutations. It's after we produced the our system starts automatically, and it's selecting the high risk variants in another file, and when we are checking it in maybe in half an hour or in 1 hour, we can detect the exact diagnosis. But we are making a second evaluation. First, we are making reporting a preliminary the report, and we are calling the intensive care unit and saying that that patient has this disorder, and then we are making a second evaluation for detecting the secondary or tertiary problems. This is working well, and after we got the T7 system, it helps us to doing it. The main problem is for many laboratories to having enough amount of patients to reduce the cost, but we are working with nearly 190 persons in our laboratory, and we have hundreds of patients at the same time. When we are getting a new urgent case, we are taking his or her blood and adding the other patients and directly uploading to the system. And that's why we can do it very rapidly. And T7 has four different systems at the same time. When we are making another test, for example, NIPT in one, and we can make whole exome or whole genome testing in the other. It's working well.
The sequencing of it being so fast is obviously very helpful. And then, as you were talking about, looking at the data and sorting through that, that's a bigger challenge nowadays than the sequencing is. Like, we want to sequence as fast as we can and obviously have good depth and other aspects to it. It's not all about speed. But Alice, can you provide a little more information about how MGI supports clinicians in helping to sort through this data and add more that Dr. Ceylaner was explaining?
Yeah, absolutely. Actually, first of all, I want to thank Intergen, Professor Serdar's lab. Actually, they being very creative, and also their research and development is also very strong. So after they get the massive data from Devon, they already can handle a lot of things by themselves. But our bioinformatics team, we are communicating very frequently. So first of all, and we also can customize some of the pipeline based on what they need. And especially for this kind of customer, they already have some of the ability to analyze this huge data. And what we are doing, we can accelerate how the efficiency and how they are going to deal with this data analysis. And especially not only for Turkey market, we are also producing some of the bioinformatics tools. For example, like AlphaCube, this one can accelerate the data interpretation and also support the clinicians with some fast and actionable results.
Yeah, that's so important. And another aspect of genetic testing that can be a burden and a hurdle for people that we talked about a little bit at the beginning is just the cost around it. And Dr. Ceylaner, you were explaining that some of it is covered in Turkey by the government, it sounds like, of that testing. But that's not always the case with every country, certainly. Alice, can you share a little more about how MGI is helping to make sequencing for these suspected rare diseases more accessible in these lower resource regions or other developing countries? Because, as you mentioned, Turkey is not the only country that MGI is serving, and there's countries, around the world that you all are working with.
I mentioned before, MGI, we are releasing new product every year. So we are we have a full portfolio from the small throughput to the high throughput machine. So for this specific area, we also design some specific sequencer for this area. For example, we have some compatible compact sequencer like E25. This one is a very small machine, and this machine is very, like, people can move it easily. And also we can do the sequencing even in a moving vehicle. And we also test this sequencer in the mountain Everest. So
Wow. That's a cool fun fact. Wow.
yeah, exactly. We are proud of our tech knowledge. So with all of this different kind of sequencer, of course, we always be sure that our sequencing quality is very good. All of them are based on our DMB-seq technology, which is a very low duplication and very high accuracy and very minimal index hopping technology. So, for example, I mentioned that this one we also focus on some area. For example, in Brazil, we support that DESA with a a complete solution from sequencing to data analysis. In South Africa, we also support the HIV genomic research with the local institute. So we are doing a lot of things locally, not only in Turkey.
Yeah. No, that's amazing. And it all comes down to can we get a diagnosis, or as we've mentioned, dual diagnoses or more for patients to be able to treat them. That's the whole reason that, we do all of this.
Yes.
Dr. Ceylaner, can you speak more to the benefit of getting that diagnosis early for people with rare diseases so that the downstream effects are different to reduce long-term complications, prevent irreversible damage, like a lot of thinking ahead. If we can get that diagnosis earlier, what can that look like for patients?
Yeah, several disorders are mimicking each other. And if you do not have a clear diagnosis, you are causing complications. And in last 20 years, I understand that complication means I missed one of the diagnoses or the real etiology. And it is very important. And it's not a rare event. That's why when we are checking the cost effectiveness of this strategy of making a diagnosis earlier, it's very effective when we compare it with the other chronic follow-up studies. Otherwise, you are trying to make the diagnosis by just clinical evaluations, and you cannot have a tool for making a differential diagnosis. Not easy. And for example, in public hospitals in Turkey, the outpatient clinics are very crowded and you have to evaluate 30 to 50 patients a day. Because our population is so crowded, several other countries sending their patients to us. And as you know, after the Syrian war, we have several immigrants also, and it's causing a big damage. And that's why we have to make a clear diagnosis. In a long-term point of view, we have to make the exact diagnosis for everything. On the other hand, as I mentioned you before, finding the secondary problems is also one of the most important things. And that's why we have to complete the Alice's sentences. We are also, do you know UDNI, Undiagnosed Disease International Network?
Yes,
Yeah.
they're based out of Boston, right? I think it's around here. Yeah.
And we are working with several countries, and we are organizing educations for those countries. We are inviting them for free of charge, and we are teaching the algorithms and everything. In the clinical side, I'm a clinician. I'm not only a geneticist, and I'm consulting everybody in the hospitals and the outpatient clinics. Sometimes I'm feeling miserable. If you do not have a genetic test, we are trying, especially in some patients, we are detecting 3 to 4 5 disorders at the same time, and it's like a mixture. It's a soup, and how you can detect the things inside the soup, it's very complicated. We have to use it. On the other hand, for the protection issues, we have to make the screening studies at the newborn period without any problem. I'm giving some lectures on traffic accidents and genetics. And in
Two
traffic,
topics I did not think would go together. Yeah.
and if you have some autoimmune disorders or immunodeficiency, after a traffic accident, you have more inflammation, more fever. And if you have a bleeding tendency, you cannot diagnose it in an emergency clinic. But if I will say that you have a Bernard Solier syndrome, most probably it is very easy to follow up a therapeutic protocol in emergency department. And that's why I also worked in an emergency department in the past, and it's a really complicated thing to make the diagnosis there, because you have a very limited time. And for example, yesterday, a family called me. In the past, nearly 2 months ago, I made a whole genome testing because their son has cardiac arrest 2 times, and during the testing period, some of the drugs also causing some allergic reactions and some other side effects and several others. But after that, I made the whole genome testing, and I completed in 10 days, and I wrote a report about all the causes of the problems, and uh, all the drugs and the metabolisms. Now they are in a surgery clinic. They are now under the surgery, and we consulted their anesthesiology team yesterday. They are now ready to for all kind of complications and several others. We have to do it. The other problem is pre-pregnancy screening. It is a very valuable thing to escape any kind of problems, especially in families who has consanguinities. We are detecting, as I mentioned, the 34% the different disorders. Some are X-linked, some most of them are autosomal recessive disorders. And some European groups are published another study, direct exome sequencing during a pregnancy without any etiological factor, and they detected that the 2.7% actionable the genetic disorders. Actionable means not only pregnancy termination, but for example, you can develop a strategy for hypoglycemia during a neonatal period and something like that. This is very valuable. And the discussion on making a genetic test on diagnosis is not an issue now. We have to talk about the population screenings. And sometimes somebodies are saying that it's a future, and not future. We have to do it today.
As a prenatal genetic counselor, I completely agree with that. Carrier screening is even more important in populations that have higher consanguinity, because if, like, I'm a carrier of a condition, so when my brother went to do carrier screening, I was like, okay, there's a 50% chance, because we're full siblings, that he's going to pop up also as a carrier of that same condition. Rare diseases are going to appear more because a lot of rare diseases, not all of them, but a lot of them are the autosomal recessive. So that makes sense. And then what you were saying with the kiddo with the cardiac events, I mean, it's just so important not just to have the diagnosis, but then to say, oh, these are medications or certain surgeries or whatever that we need to be mindful to not give, not just the ones to give, but you were saying like allergic reactions and everything, that it's so important to have that baseline information from exome or genome sequencing to then be able to actually treat someone, and in a quick way. I would love to wrap up with getting some ideas about the future. So Dr. Ceylaner, you already mentioned a little bit. So Alice, I want to get more of your thoughts on what innovations is MGI and yourself just most excited about for this future of sequencing, rare disease diagnosis. What is on the horizon that you're like, this is going to be big, or it could be big?
Actually, just now, Professor Serdar, he mentioned that we need to do this newborn screening. I cannot agree anymore. For this one, as MGI, we support more than 20 projects to have this national genome project, which actually it's a very efficiency way to enable this early detection for this kind of risk factors. But unfortunately, in Turkey, we are not doing that. I'm really looking forward that in one day, for example, we can cooperate with Professor Serdar and we can have this kind of national project in Turkey. And as MGI, we are focused on the technology itself. We are a research and development company. We focus on all of these innovations. Innovation is MGI. MGI is innovation itself. So for MGI, actually this year, we launched that Seek-All portfolio. This Seek-All help people to do both short reads and long reads sequencing just in one platform. Actually, Professor Serdar, as I mentioned, they are our KOL, our reference lab. And every time when MGI has something new, they are one of the first one that to try it and
They're
experience
VIP.
it.
They get early access.
Yeah, exactly. And they also help us a lot to improve our performance, to improve the design and etc. So, for example, this single cell technology, also Professor, they were the first one in Turkey to experience this new technology of MGI, and they did a very good, successful demo run. And after their demo run, we are confident that we can release these applications in Turkey. And what I mentioned now, both short reads and long read sequencing can sequence both on MGI platform. And Professor Serdar, they also experience our long reads technology, which we just released this year. And what's more, we are also the only company that mastering all three different kind of sequencing signal detection methods. For example, the excite luminous, the self-luminous, and non-luminous technology. And we also develop the G400RS flow expert. And this one can combine the high throughput sequencing with multiplex immunofluorescence, and it has a built-in AI assistant support the users with the intelligence code generation and also analysis. And what's more, we also cooperate with a lot of other excellent users like Professor Serdar's Intergen. For example, Negedia in Italy, we are expanding our spatial transcriptomics and for the rare disease and oncology research across the Europe. So I think the future innovation for genetic area is that we are keep developing, keep going for the innovation and develop more and more applications for the people, for the excellent scientists like Professor Serdar to use. This kind of tools is for them to use to make the clinical develop faster and give all of the benefits to the patient, to the globally all people.
You're so right that newborn sequencing is going to become the standard. So, in countries where we have newborn screening, it is going to be replaced by sequencing. And we already have these projects popping up in different countries to pilot this. And, especially, in the NICU settings is kind of the place to pilot that, certainly. Dr. Ceylaner, anything else to add in terms of what advancements like you hope to see or that are beginning to emerge?
Yeah, we are now starting to use the AI system, but we must arrange everything as an automated system. It may sometimes cause some affairs. It's very valuable because we need time. It's a very urgent thing to make a diagnosis in clinical genetics, and we are now just thinking about the chronic disorders. When we are trying to reach this kind of systems, we will make the diagnosis of several very rare infections also, not only genetic disorders. I'm looking from this point of rare diseases because I'm the head of the European Rare Disease Committee, and we are not evaluating only the genetic disorders and infections, and everything must be checked on the same platform as soon as possible. Sometimes they are mimicking each other. These technologies must be placed in all hospitals. And now we are working on sepsis issue, for example. It's a big problem, and sepsis sometimes mimicking metabolic disorders, and both is very common in Turkey and some other neighbor countries. And making a differential diagnosis is not so easy, and sometimes they are seems like a big mixture, both sepsis and metabolic disorders together. Yes, we have to start to use this technology worldwide. And now we are also working with World Health Organization. We discussed this issue for several times and trying to develop a new social security system covering all the world, because yes, the lower income countries have some problems, but they are paying this that less money their less money for the health issues. It's a big problem, but they have to develop their education and some other problems. And we may move together. I think this is the most valuable one.
Yeah. Well, thank you both so much for sharing all of your insight. I mean, we covered so many interesting topics between just how the genetic testing landscape is in Turkey and how Dr. Ceylaner is taking advantage of MGI's sequencing and bioinformatics and everything that you all offer to then be able to treat patients, and especially with a patient population with the higher consanguinity and more rare diseases. Just really, really interesting of just everything that we were able to cover today. So Alice and Dr. Ceylaner, thank you so much for coming on and sharing all of this with me.
And thank you again for your invitation. It was a nice thing to come here. We are inviting you to Turkey.
Looks like I'm planning a trip, everybody. See you in Turkey. Thanks for watching DNA Today. To access all of our episodes, head over to dnatoday.com. We also have a lot of bonus content on there that you can enjoy. If you have any questions, comments, suggestions, guest pitches, you name it, send them in to info@dnatoday.com. We'd also really appreciate if you could take a moment to rate and review the podcast on Apple, Spotify, wherever you listen to the show. It really helps more nerds like yourself find the show. Also, if you like giveaways and other ways to connect with us, I recommend following us on social. We're at DNA Today Podcast. We also have a Patreon if you want to be the most level involved in the show. That's also at DNA Today Podcast. Thank you so much for listening and watching. Join us next time to learn and discover new advances in the world of genetics.